Hi there. Thank you for inviting me to present at this conference in beautiful Galapagos. I'm sitting here in Vancouver Island in Canada, and it's very, very cold. So I wish I was with you all. Thank you, Dr. Furman Martinez, for inviting me to present at this conference. Dr. Furman and I work together in the IDF, the International Diabetes Federation. We put these guidelines together in 2017 with a group of practitioners from all over the world. The goal of the guideline was to protect the diabetic foot from breakdown, ulcers, amputations, to teach healthcare practitioners to treat urgently in the window of presentation when the patient presents with neuropathy, but before an ulcer opens up. That is the key. And we also organize the implementation of these simple pocket charts to teach healthcare practitioners globally how to do a quick 5-minute diabetic foot exam to risk categorize the patients, assess, treat, and refer. So these are really important guidelines. They're broken down into multiple sections: the introduction, neuropathy, peripheral arterial disease, infection, ulceration, Charcot foot, and again, the pocket chart. These are on the IDF website. I recommend that you all take a look at these. They're excellent guidelines that will simplify this whole process of protecting the diabetic foot. What we really want to do is figure out immediately when we see these patients, and these patients should get assessed at the minimum once per year, and more often if they're in a higher risk category. Are they in risk category 0, which is no neuropathy, 1, which is some neuropathy, 2, which is the high risk foot, which is neuropathy plus something else, onychomycosis, poor circulation, structural problems, or risk category 3, which is the urgent risk category where they've had an ulcer, an amputation, or a Charcot foot, or a history of that. These are the risk categories. We want to see these patients earlier and treat them earlier so they never actually get to risk category 3. This is the simple pocket chart in which a 5-minute diabetic foot exam can be done. And that tells us how to treat the patients. What do they need? The goals of the guidelines are mobility. Keep them on the ground walking so the patients can manage their glycemic levels and prevent neuropathy. As soon as their blood sugar levels get high and it causes neuropathy, now the patients are going to have balance issues. They're not going to walk if they have balance issues. They're not going to walk if they have a painful foot condition. So that needs to get treated. And they're not going to walk if they feel like they're doing more damage. So we need to, as best, keep them mobile so they can keep their blood sugars at the A1C of 7 or below. And if they are progressing up the risk categories, we want to have an early intervention. Again, risk categorizing or finding them in risk category 1 and 2, not waiting till they get to 3. We want to protect these patients. We're urging all healthcare practitioners to figure out how to see the patients earlier in the window of presentation and treat them earlier, well before an ulcer happens. As soon as we get an ulcer, it's way more difficult to treat. As we know, glucose is a highly reactive compound. It wreaks havoc. This is what the cause of neuropathy. The blood sugars damage the endothelial lining on the smallest blood vessels in the foot. This kills off the nerves in the feet. If there's not blood to nourish the nerves, there's not nerves to innervate the blood vessels. There's an interplay between the two. With the damaged blood vessels, we start to get the death of the nerves. That is neuropathy. It affects the sensory nerves, and they lose their ability to protect their foot, and they can walk wounds into their feet. They also, and 70% will, as time marches on, get some level of loss of protective sensation in their feet. It also affects the motor nerves, the motor neuropathy. So we get what we call the intrinsic minus foot. This is the distortion of the foot. The intrinsic muscles below the ankle are starting to die off, and the ones above the ankle are distorting the foot into what we see here. We're starting to get this increased arch height, this increased metatarsal head pressure. The fat pad protecting the metatarsal heads is pulled distally. The fat pad protecting the heel is pulled distally, further exposing those two peak pressure areas. There's clawing in the toes, and now there's peak pressure on the tips of the toes. This also has to do with the high blood sugars causes the glycosylation and the cross-linking of the collagen, and it stiffens up the foot. And now the foot is unable to do what it's supposed to do, which is absorb shock on walking. So we see this deformation of the diabetic foot, and it puts the patient at a higher risk, because if this is a 200-pound patient, when in normal gait, they stand on one foot for a period of time, all that 200 pounds is going through the metatarsal heads and the calcaneal tubercle. So you can see when you have a round surface on a flat surface, you get a small contact area. You get areas of high peak pressure. So all the peak pressure is going through just those areas, the metatarsal heads and the heel there. And that's the most common area to ulcerate. The body tries to protect with calluses. Calluses open up into wounds. Wounds can get infected, and that leads down the very deleterious pathways to amputation. But that's not the most feared problem. The ultimate consequence is the Charcot-Neuro-Osteoarthropathy. That is the collapse of the foot. This traumatized foot, in the absence of feedback, because of the neuropathy, the person can walk, traumatize the foot. The inflammatory markers and increased blood flow comes down to the foot, but the peroneus, the extensor muscles, and the Achilles are still strong. So they bowstring the foot and they collapse the foot below. It collapses like a bag of bones. So now we have the bones of the foot are now collapsed below, and an ulcer will open up. This is the ultimate consequence. The foot no longer looks like a foot. It's no longer a shoeable foot. This is what we need to avoid here. So we can, first we start with the diabetic foot exam, assess with our 5.07 monofilament with 10 grams of pressure. We are assessing their level of neuropathy, put them in a risk category. Then we know we need to start offloading them. It's not medicine, it's mechanics. Offloading is taking the pressure and redistributing it. Pressure equals force over area. Force is the body weight. Surface area is where we can interface. If we increase the surface area, we can decrease the peak pressures coming down that cause these ulcers and the Charcot foot and all these deleterious consequences. How do we do that? We do that with custom foot orthotics to decrease the pressures coming down, to increase the surface area. We can also do it with diabetic footwear, which will increase the surface area. This will help protect the diabetic foot. We really need to remember that the diabetic foot is a disease process of its own. It can't just be lumped into the rest of the diabetic exam when these patients see their general practitioner. These patients need an assessment minimum once a year, and if they're in a higher risk consequence, then even more often. I've only spoken for 10 minutes, but the death rate from diabetes and its complications is actually 1 every 6 seconds. So in the course of this 10-minute presentation, 100 people have died globally from diabetes and its complications. When we know more, we can do better. So now is the time to act. Again, thank you for inviting me. This was a quick snapshot. I've actually never done a 10-minute presentation before. I usually do an hour. And I usually like to speak with differentiating lumbar spinal stenosis causing neuropathy from the top down from diabetic neuropathy from the feet up. It's so important to differentiate those. So I hope I get to join you next year, and we'll have an even longer one. Thank you for inviting me. Have fun in Galapagos.